Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, Mr. Feldman. How are you today?
My leg's killing me.
Okay, Mr. Feldman, I'd like to take a look at your leg now, if you don't mind.
Sure.
I'd like you to lie down, if you would, please.
Okay.
There you go. Based on what you've told me so far, I suspect you have a problem with the circulation in your leg and that the arterial blood flow might not be as good as it could be. And so I'd like to proceed to do an arterial circulation examination. I suspect the patient suffers from peripheral vascular disease, and so I would like to do an arterial circulation examination, beginning with the femoral pulse.
Femoral pulses are normal bilaterally, no bruise heard. Please move on.
Okay. Mr. Feldman, I'd now like to take a look at the pulse behind your knee. I just need to bend your knee a little bit, and you're going to feel me pushing behind it just like this as I look for the pulse. This one can be hard to find sometimes. So with the knee in a slightly flexed position, I'm assessing for popliteal pulse intensity bilaterally. Popliteal pulses are equal and normal bilaterally. I'd now like to proceed to do more an evaluation of the peripheral circulation, and I will compare both sides. So with your leg nice and straight, I'm assessing for the posterior tibial pulse on both sides, as well as the dorsalis pedis. I feel both pulses present, equal and bilateral. I'd now like to move on and do another examination looking for some of the physical signs of vascular insufficiency. And this would include looking for changes in the skin, hair on his feet, his nails, as well as looking at dependent rubor and pallor on elevation. So Mr. Feldman, I'm just taking a look at your feet. I see that your skin looks normal. You have some hair, which is normal. You have a good capillary refill, which means that the circulation in the very small vessels of your feet is good. Now I'd like to proceed to special maneuvers, and this would include looking at pallor on elevation as well as dependent rubor. Mr. Feldman, I'm just going to lift your leg a little bit. Okay, you don't have to do anything, just relax. So normally I would maintain the leg in the air like this for about 2 minutes and be looking at the foot for pallor. A little bit of pallor is normal, but...
Noted. You may move on.
Okay. And now if I could have you sit up, Mr. Feldman, and just have your feet hang over the side of the bed for me. There you go. All right. Again, I would suspect that this would take a couple of minutes before I would see any redness. Are you okay?
That is the end of Part A. Now look at Part B. Extract 2, questions 13 to 24. You hear a neurologist talking to a patient called Vincent Chung. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Vincent, I've got your referral notes from your GP, but I wonder if you could tell me in your own words how this all started, what treatment you've had, how that's gone, and anything else you think I should know.
Thank you, Doctor. Yes, well, it all started about 3 months ago. I was just washing one morning, and everything was completely normal, when suddenly I felt a pain go right across my face, for no apparent reason. Then, after that, the attacks came quite often. If I had to describe it, I'd say it's like a searing pain, and it usually hits the right side of my face. Like I said, it goes right across it, but it's my cheek, teeth, and my jaw that seem to take the brunt of it. It's a horrible feeling, too. It feels like an electric shock. I have to say, it leaves me feeling quite shaken.
And have you noticed any patterns or triggers? Is there anything that seems to bring this on?
Well, like I told you, the first time it happened, I was washing my face, but now I notice that brushing my teeth and shaving also bring it on. It seems to be anything to do with touching my face. I mean, even the wind can cause a sudden attack of pain. And also just using my face or mouth can bring one on too. So, I mean, like, just eating and drinking can cause one. Or smiling at something suddenly, or for a long time. Basically, anything fun, pleasurable, or necessary seems to cause me horrendous pain.
And do you think that the condition's developed or changed in any way since your first attack?
Oh, they're definitely happening more often. And not only that, it feels like they're affecting my whole face. At the beginning, the attacks probably only lasted about, 30 seconds or so? But nowadays, I find myself dealing with the really painful part of the attack for a few minutes at a time. And it's actually getting severe now. I used to be able to cope with the pain by clenching my fist or talking myself through it or whatever, but I can't now.
And I see here that your GP prescribed you some medication. Has that helped at all?
Well, I expect you can see on my notes what I'm on. My doctor was reluctant to give me anticonvulsants at first because apparently there are 1 or 2 that can cause serious reactions.
Yes.
But he found one that carried a very low risk, so I was on that for a time. Anyway, after a while they started to lose their effect, so then he put me on antispasmodics. That's what I'm on now. I don't know if it's relevant, but I also take supplements, cod liver oil and vitamin D.
Okay. How are the antispasmodics working out for you?
Well, I have to admit that when I take them, the pain is a bit more bearable, but they do affect me in other ways. I mean, I'm drowsy all the time. I can hardly keep my eyes open. And just trying to follow a conversation or remember what it is I'm supposed to be doing has become a challenge. It really doesn't take much to make me confused. I mean, it's embarrassing. So, to avoid people thinking I've completely lost it or whatever, I've ended up staying at home a lot of the time.
Oh dear.
Now that's something I've never done, and I think it's that more than the pain which has led to some very strange mood swings. I mean, that's not really like me, Doctor.
I see. Well, from what you've been saying, it sounds like we need to book you in for some tests and explore the possibility.
This is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which best fits according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a discussion between a doctor and nurse about different types of kidney cancer cells. Now read the question.
Hello, doctor. What are the different types of kidney cancer cells?
Well, there are about 10 different types of kidney cancer cells. Clear cell is a very common type of cell found in about 70% of kidney cancers, which may be slow growing or grade 1 and less aggressive, or may be grade 4 with a very aggressive growth. Clear cells are susceptible to treatment with immunotherapy and targeted therapy. Papillary cancer cells is seen in 10% to 15% of patients and has further subtypes called type 1 and type 2. Sarcomatoid cells grow most aggressively of all types of kidney cancer cells. It may be found with clear cell or papillary type. The cancer cells appear like sarcoma cells under the microscope. Collecting duct cancer is similar to transitional cell carcinoma and is rare and is usually treated with chemotherapy. Oncocytoma is a slow-growing cancer and does not spread beyond the kidneys. Chromophobe is another type of rare cancer. Angiomyolipoma is a non-cancerous tumor that has a unique appearance on the computed tomography scan. This type of cancer is less likely to grow aggressively and spread, and is treated surgically. Question 26. You hear a discussion between a doctor and nurse about fibrosis. Now read the question.
Hello, doctor. What is fibrosis, and what are the different types of fibrosis?
Well, the term fibrosis means the formation of fibrous tissue that may or may not be connected with tissue healing. Some of the different types of fibrosis are: lung fibrosis or pulmonary fibrosis may occur as a result of prolonged infections, such as tuberculosis or pneumonia. The condition is also caused by exposure to occupational hazards, such as coal dust, or the genetic condition called cystic fibrosis. Liver fibrosis or cirrhosis refers to the scar tissue and nodules that replace liver tissue and disrupt liver function. The condition is usually caused due to alcoholism, fatty liver disease, and hepatitis B or hepatitis C. Heart fibrosis affects the regions of the heart that have become damaged due to myocardial infarction may undergo fibrosis. Mediastinal fibrosis is characterized by calcified fibrosis of the lymph nodes that can block respiratory channels and blood vessels. Retroperitoneal cavity fibrosis affects the soft tissue in the retroperitoneum, which contains the aorta, kidneys, and numerous other structures. Bone marrow fibrosis, or myelofibrosis, is scarring in the bone marrow that prevents the normal production of blood cells in the bone marrow. Skin fibrosis is the scar tissue that forms on the skin in response to injury, called a keloid. Scleroderma or cystic sclerosis is an autoimmune disease of the connective tissue that initially affects the skin, but also involves other organs such as the kidneys, heart, and lungs. Question 27. You hear a discussion between a doctor and a nurse about autophagy. Now read the question.
Doctor, what is an autophagy, and what are the types?
Well, autophagy is a process which includes the consumption of the body's own tissue during a metabolic process that occurs due to starvation and in certain diseases. The different types of autophagy are: macroautophagy processes involves delivery of cytoplasmic cargo to the lysosome through the intermediary of a double membrane bound vesicle, which is called an autophagosome, that fuses with the lysosome to form an autolysosome. Microautophagy. During this process, the cytosolic components are directly consumed by the lysosome itself through the lysosomal membrane. Chaperone-mediated autophagy. During this process, the targeted proteins are translocated across the lysosomal membrane in a complex with chaperone proteins. Question 28. You hear a discussion about the role of epinephrine in human body. Now read the question.
Hello, doctor. What is the role of epinephrine in our body?
Well, triggering fight or flight response is the role of epinephrine in our body. This occurs when a person is subject to a threat, which causes a signaling process to occur, leading to our reaction to the potential danger. Epinephrine and liver cells. One of the places where epinephrine has an effect is in the liver. Epinephrine, along with another hormone called glucagon, is responsible for the breakdown of glycogen in liver cells. Epinephrine and the lungs. The lungs contain smooth muscle. Epinephrine causes smooth muscles to relax. Specifically, epinephrine binds to beta-2 adrenergic receptors on bronchial muscle cells. Epinephrine and the skin. The effect of epinephrine on the skin is mainly caused by it binding to alpha-adrenergic receptors, the alpha-2 adrenergic receptor in particular. Epinephrine and the heart. Epinephrine binds to beta-adrenergic receptors on heart muscle cells. This causes the contraction rate of the heart to increase. This ultimately leads to increased blood supply to the tissues in the body. Question 29. You hear a lecture about ringworm diseases. Now read the question. Ringworm, or tinea, or dermatophytosis, is a common skin and nail infection caused by fungus. Because the disease causes an itchy, red, circular rash, the disease is called ringworm. The different types of ringworm are usually named for the location of the infection in the body. Areas of the body parts that can be affected by ringworm are: tinea pedis, infects the feet, which is also called athlete's foot. Tinea cruris, infects inner thighs, groin, or buttocks, which is also called jock itch. Tinea capitis infects the scalp, and tinea barbae infects the beard. Tinea manuum cause infections in hands. Tinea unguium, or onychomycosis, infects fingernails and toenails or fingernails. Tinea corporis infects other body parts such as legs and arms. Question 30. You hear a discussion about different types of rheumatoid arthritis. Now, read the question.
Hello, doctor. What are different types of humanoid arthritis?
Knowing the exact type of rheumatoid arthritis will be very helpful to provide an appropriate treatment to the patient. Types of rheumatoid arthritis include: if a patient has seropositive rheumatoid arthritis, the blood test result would show a positive rheumatoid factor. This means the patient has the antibodies that cause the immune system to attack the joints. Juvenile idiopathic arthritis refers to rheumatoid arthritis in people younger than 17 years of age. The condition was previously known as juvenile rheumatoid arthritis. The symptoms are the same as those of other types of rheumatoid arthritis. However, they may also include eye inflammation and issues with physical development. If the patient has a seronegative rheumatoid arthritis, the blood test would show a negative rheumatoid factor and a negative anticyclic citrullinated peptide. But if the patient still has rheumatoid arthritis symptoms, it may be probably a seronegative rheumatoid arthritis. The patient may eventually develop antibodies, changing the diagnosis to seropositive rheumatoid arthritis.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Inducing labour, that's breaking a woman's waters and making the uterus contract more strongly. Is it safe? It's an important question, and a large randomised trial has found the answer, at least for some women. The lead author was Bill Grobman, who's Professor of Obstetrics and Gynecology at Northwestern University in Chicago. I spoke to him earlier.
What was being tested was the concept that for many years there has been a belief, really deeply ingrained, that labour induction leads to a greater chance of cesarean delivery. The truth is, though, that it's based on relatively long ago studies for which, and I'm happy to describe why, there has been a fundamental misinterpretation of the results such that we misunderstood the clinical implications.
Well, let's just talk about this misunderstanding. And just to be clear, when we're talking about labour induction, we're talking about breaking the waters and putting up a drip which makes the uterus contract.
When we're talking about labour induction, there's not a single way to do it, but that typically you're right.
So was the problem in the past that labour induction was done on women in distress and therefore it was a biased population? They were already in strife when they were induced?
Well, I think it's actually two issues. One is the issue that you already referred to, which is that so often women were being induced for a medical reason. Something else was going on. Either the fetus was in need of being delivered or the mother herself had a complication that led to delivery being recommended. And clearly those were both situations that led to a higher chance of cesarean. But the other really important thing was that the studies that were done, and when I say studies, I very much mean observational studies, not trials, but studies where people went back and looked at records of women who had delivered, where women who were being induced were compared to women in spontaneous labor at the exact same gestational age. And I think it is undeniable that if you make that comparison, that there's a greater chance of cesarean among women who were being induced than women in spontaneous labor at the exact same gestational age.
Why is that?
Well, I don't know why it necessarily is, but it just is. It's something that's observed, something that when people studied it, not with the clinical trial, but with observational data, that happened, and very consistently.
But these are biased studies because they weren't randomized.
Let me put it this way. Induction of labor is an option. I can choose to be induced or not to be induced. Spontaneous labor is not at the exact same day is not an option. Women may spontaneously have a labor, but also may not. They may not go into labor for another 2 weeks, and every week that goes by, the chance of cesarean increases. They may not go into labor and get to a point where induction of labor becomes recommended, but now it's an induction 1 or 2 or 3 weeks later. And so if you're making a clinical decision, and the clinical decision is, do I choose to be induced now or do I not? The alternative is not spontaneous labor on the same day.
It's waiting.
The alternative is waiting, which may end up in spontaneous labor but may not, or may end up in spontaneous labor weeks later. And when observational studies were constructed like that, studies that reflected the actual clinical situation, you actually very consistently did not see the association of induction with cesarean delivery.
So now you've done a randomized trial where you actually get women and you randomize them to induction or waiting.
That's exactly right. So,
and this is in women who've never had a baby before.
That's right. And so that's, I think, an important point. Most of the concern with regard to cesarean delivery was with regard to women who had never had a baby before, women on their first birth. And I should also say this isn't about women who have medical complications for which there's a medical indication for induction. This was really a question of women who had no other reason, no standard reason to have induction recommended. Was it indeed true that induction would lead to an increased risk of cesarean, or might it be, as the more recent observational studies suggested, that induction didn't increase or even decrease the chance of cesarean and maybe also improve the outcome of their baby? And
sitting behind this is a concern about a high caesarean section rate, complications in second pregnancies. You're kind of condemning yourself or committing yourself to a second caesarean, and sometimes the babies don't do as well.
I think what we would say is that, for any woman who desires a vaginal birth, that we want to do everything we can to try to optimize that chance. And clearly, if someone can have an uncomplicated vaginal birth versus an uncomplicated cesarean, both in terms of short-term complications and long-term complications, including complications for future pregnancies, it's preferable to have a vaginal birth. What we want to get rid of are unnecessary cesarean deliveries that would have potentially preventable, and the health of the mother and her child or children are preserved.
Okay, so you took about 3,000 women, not a small study. Well, it's actually, 6,000 women.
Yeah.
3,000 were assigned to labour induction at 39 weeks, and 3,000 waited to see whether they went into spontaneous labour, and they were low risk, as you said. And your outcome was mother's health, baby's health, and caesarean section. Is that right?
Yeah, that's exactly right. It was 3,000 women in each group, low-risk nulliparous women or women on their first birth, randomized to induction at 39 weeks or expectant management or waiting. And not forever, because there's still an upper limit at which in the modern day is considered sort of acceptable practice, but till about 42 weeks would be the upper limit.
What did you find?
Well, what we found was that women who were randomized to labor induction had a significantly lower chance of cesarean delivery, so about a 15% relative risk decrease in cesarean delivery. Women who were randomized to induction of labor delivered babies who were significantly less likely to need extra respiratory support, like having a tube put down their throat to help them breathe or requiring high amounts of oxygen. Women who were induced had a lower chance of having high blood pressure problems at the end of their pregnancy, sometimes called preeclampsia. And also they reported less overall pain, and they reported a greater sense of control over their labor process and a greater sense of agency.
Well, that sounds pretty impressive. We'll come back to the implications in a moment. But one of the risks here is you get the scent of the patient.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Five years ago in Victoria, a baby died during a planned home birth. The coroner recommended an investigation into the extent of problems arising from home births. One of the results of this recommendation have just been published. A study comparing thousands of women having their babies in hospital with women having a planned birth at home. Miranda Davies-Tuck was the lead author. Miranda is a perinatal epidemiologist at the Hudson Institute in Melbourne. Welcome to the Health Report, Miranda.
Hello, thank you for having me.
Now you took data from 15 years. It's an impressive number of women.
16 years, 2000 to 2015.
Sorry,
inclusive.
maths was never my strong point. So So you were comparing women who went for home births to women who went into hospital. What sort of numbers are we talking about here?
So there are around 4,000 women who planned a home birth and just over 800,000 who plan to give birth in hospital.
And we're saying planned because these aren't women who couldn't get to hospital and had the baby at home. These are women who just wanted to have a private delivery from a midwife.
Yes, so these were women who had made a decision at the onset of their labour to plan to give birth either at home or in hospital.
How did you do the study? What were you looking for and how did you compare the two sets of women?
So we use the routinely collected data that we have for Victoria. So every time a baby is born or a woman is pregnant in Victoria, a whole host of information is collected and reported to the Department of Health so that we can monitor the health of women and babies in Victoria. And so we access that data to compare the outcomes after we classified them as either planning to birth at home or planning to birth in hospital and whether they'd be deemed to be of high or low risk of having an adverse outcome.
So describe a pregnant woman who's low risk and a woman who's high risk. What sort of factors are we talking about here?
So generally speaking, a low-risk woman is a woman who has a healthy pregnancy. There's nothing majorly wrong with her or her baby. There's only one baby that she's carrying, so she's not having twins. And she hasn't had a previous complicated pregnancy, so one that's ended in a caesarean, for example. In contrast, the women who would be considered or who were considered high risk were predominantly women who had had a prior caesarean delivery. They were also women who were giving birth beyond 42 weeks, so we call that post-term. And then there was a smaller subset of those women that had more than one baby, whose baby was breech, so it wasn't head down, or they had some sort of serious medical condition such as hypertension, etc.
Okay, so like for like, but the difference was the home birth or not. I mean, was it truly like for like? I mean, were women having their babies at home more likely to be better educated, higher income?
Yes, so we saw that regardless of whether they had risk factors or not, they tended to be healthier, older women of a higher socioeconomic standard, if we use what we call CFA. It's a way we categorise them. It's not surprising though, because the women choosing a home birth in this study were doing so privately, so they were paying out of pocket to do that. The type of risk factors were slightly different too. So the high-risk women in hospital were more likely to have medical conditions, which was a little bit higher than the women who planned to give birth at home.
Before we get to the results, did that influence the results, do you think, or were you able to control for all that?
So we made the decision not to control for anything in this study. We weren't interested in the relationship between home birth and outcome, but what we wanted to do was to provide information in a way that women would be able to work out where they sat in that particular group and then make decisions about what their outcome rates would be if they did or didn't have risk factors and if they chose to give birth in home or hospital.
So what did you find?
So that we found that for the low-risk women, there were no differences in perinatal death. So babies were not more likely to die for women without risk factors planning to give birth at home.
So when you say perinatal, was that the first week of life?
So perinatal death includes stillbirths that occur during labour and also deaths in the first 28 days of life.
Okay. So no difference in perinatal death. What about other baby outcomes?
So in terms of some of the morbidities or the bad things that can happen to babies, some of these were actually lower for the women who plan to give birth at home. So their babies were less likely to have an injury and they were less likely to have some of the other morbidities that can occur. But this probably reflects differences in some of the intervention rates that the low-risk women, so they were less likely to have instrumental deliveries and caesarean deliveries, so possibly it could be related to that.
What about the high-risk women?
So for the high-risk women, we didn't see that the perinatal mortality rates was the same. In fact, we saw that...
You got a tripling, didn't you?
No, it was actually 7 times more likely to have their baby die if they planned to give birth at home. Yes, so neonatal death was so death after the baby was born was the death rate that was significantly higher in the women.
For what reason? I mean, there wouldn't have been large numbers, but what reason?
No, so the numbers were very small. We can. It's difficult to talk about the drivers of this because the numbers are so small, but it did look like the The babies that were born at home were the ones that died. These were not the babies that transferred to hospital during labour.
So if you've got into problems with a planned delivery and you transferred to hospital, you were okay. It was just if you got into strife, then that's the women who got into problems with their babies.
Yeah, and potentially there were barriers to the transfer to hospital. Whether or not those barriers still exist right now, we can't be certain.
But all the maternal benefits and the other benefits were there in the high-risk women. It was only that risk of perinatal death that was the issue. Now, there are all sorts of... So in other words, it's basically good news as long as you've got your risk assessed and you're going into this with your eyes open.
Yeah, absolutely. And it's really good that we've been able to show for Victoria what we already know for international studies. So the UK data has been telling us this for a long time, but we didn't have any data to inform us here. So it's good to see that what we're seeing here is the same as what they're seeing in the other big studies internationally.
Now, there are big issues here. Midwives are supposed to have an obstetrician who covers them, and they often find it hard to find an obstetrician who's prepared to cover the midwife and look after them. The midwife feels that they're not easily able to transfer the baby. There's a problem with payment and insurance, getting indemnity insurance. Are we overcoming those barriers yet?
Yes and no. I think certainly a lot of the barriers to transfer are decreasing. We have collaborative arrangements now where hopefully midwives are feeling comfortable backing up and consulting with obstetric staff when women need care. Certainly we see from the data that we have that when a woman has been identified as needing to transfer and transfers to hospital, her outcomes are fine. So in those instances, absolutely.
And just very finally, very briefly, because we're well over time, is this applicable to other jurisdictions in Australia, do you think?
I would say yes.
In addition.